Good afternoon, everybody. I think we should start. Also, we don't want to. We want to have, plenty of time for discussion. Hopefully, some people will join us during the session. So, welcome to this session about people-centered choices and support people-centered choices in determining treatment option for people with opioid dependence. During the preparation, we thought that now we have a number of multiple options for people. It's important to understand how these decisions are made and how we can put and facilitate people making their own informed decision. So we'll have a panel going through different aspects of the same problem. At the end, we hope to have at least 30 minutes for a panel discussion. So I will ask you to hold your question for the end. And we'll be as strict as possible in terms of keeping the speakers to around 10 minutes. I will introduce myself and then give the floor to my co-chair. My name is Mauro Guarinieri. I'm Italian, living in France. I'm working for the international network of people who use drugs. We're based in London, but we have staff all over the world.
Thank you, Mauro. So I'm Perrine Roux. I'm a research scientist in public health based in Marseille, France. I work on harm reduction, HIV field. We are pleased today to co-chair this session with Mauro, and we would like to thank INPUD, which has invited us to organize this session. In a context where we have a wide set of therapeutic options for opioid dependence, we have also different drug policies, different models of care. This session aims at understanding how to better take into account the patient preferences in the choice of treatment, but not only treatment, also follow-up, condition for distribution. So it seems to be a very crucial question, which is complex, and we would like to discuss this point with you today. So we also have to INPUD would like to thank Camerus and Indivior, which has funded, supported this session. But we also would like to acknowledge that we have no conflict of interest to declare. And in addition, the sponsor have had no input into the content. That's important. So this is a session program. So as Mauro told, we wanted to have several perspectives. Clinical perspective, social science perspective, community perspective, and implementation perspective, and a policy perspective. So I'm going to give the floor to Professor Marc Auriacombe, who is a professor in psychiatry and addiction medicine based in Bordeaux, France. So Marc, it's to you.
Okay. The slide.
Here. Okay.
Okay. Right.
Here we go.
Okay. Thank you, Perrine and Mauro, for the introduction. I'm very excited and delighted to be at the conference. I'm very stressed to be speaking in this session. I'm happy at the same time, but just to share some of my emotions. And I need to stick with time, so I should not waste too much time talking about myself. I'll be opening the session on the clinical perspective. So the perspective from addiction, psychiatry, not forgetting the user choice perspective. So why do some people use opioids as a start? Opioids is a heterogeneous group of substances that have very different effects. One of those effects that should not be forgotten is that it's positive reinforcement, pleasure. the condition to experiment pleasure from opioids or from any source for that matter, whether it be substances or not, is to be in a steady state normal condition where then you can take advantage of the pleasurable effect of opioids. The advantage of experiencing pleasure is that it's something that is needed for good mental health and good general health. It's a normal behavior to experiment pleasure and to anticipate experimenting pleasure over time. That's what we are built for. The risk related to experimenting pleasure and organizing oneself to be able to experiment pleasure in different settings is loss of control over use that can occur and which is the core of addiction. But opioids have many other effects and they can also alleviate impairment, especially pain, anxiety, depression, and psychotic symptoms. The conditions to experiment those effects is to be in a non-normal state, to be in a state where you have either pain, anxiety, depression, or psychosis. Then the opioid will correct the abnormality. So it's a so-called treatment or self-treatment if it's self-use. Relief of impairment is needed for good health. When you are in an impaired condition, it's not a stable condition, and the individual will seek alleviation of impairment. That's normal behavior. The risk is lack of access to the optimal answers, which in our societies should be mental health services. Regardless of why individuals use opioids, there are risks related to the use of opioids by themselves, whichever drives motivation for use, which are related to risk of overdose, withdrawal, and tolerance, that are fairly easy to overcome through user knowledge about how to use, like, how do you drive a car safely? How do you use opioids safely? Now, health professionals and opioid users need to share information because, as we've seen, there are a diversity of effects and experiences for users of opioids. And health professionals have a diversity of prescription goals and outcomes. One can be and should always be concerned about overdose prevention, pain management sometimes, if there is pain, withdrawal management, psychopathology management, and craving management are all possible medical goals. And there needs to be a good enough time to share knowledge between the user and the health professional to be able to achieve the good match. The other thing we need to keep in mind is that not all opioids have the same effects, and route of administration contributes to the final effect. The higher the intensity of euphoria and the shorter time to achieve intensity, so the quality of the pleasure, is also related to an increased risk for addiction. This is not specific to opioids. It's the same case for tobacco, for alcohol, or for reading, or any source of enjoyment of pleasure. Some opioids, however, we should know, have a very low quality euphoria, such as methadone or buprenorphine, for example. So, by the way, this is very important. So if someone who has experience with heroin receives methadone or buprenorphine, but is not clearly informed that what he will experiment with methadone and buprenorphine is uniquely different from what he experienced with heroin, there's going to be a mismatch. There's going to be a misunderstanding. And then the route of administration will contribute to the final outcome. Intravenous, intranasal, and smoking reduces delay. This is true for opioids, but also for tobacco or cannabis. And by reducing delay, it might give the impression that it is more euphoric, but it just does whatever it does more quickly, not necessarily better quality. Now, what is addiction from the medical perspective or use disorder? It's not just using even a lot. It's a special condition where there is loss of control over use. So the experience of someone who has addiction is that he's not using as he wants. He's not using to the goal he wants to achieve. And this translates through relapse and craving. There are pre-existing factors and risk factors that can contribute to this, and if they exist, once addiction is there, the individual will also have these pre-existing factors, but not always. And of course, there are consequences. For a very, very long time, we focused on only the consequences of addiction and not what is actually core to addiction. When you only address consequences of a problem, the problem still repeats itself, and everyone becomes desperate. And the time is?
We have 3 minutes.
Okay. So there are two targets for the treatment perspective. One, traditionally on withdrawal management, which is a consequence, and one which is more core, more likely to change outcome, which is management of craving. And there's data that now allows us to say that craving actually drives behavior. When craving increases, it increases the risk of using against one's planning, and when craving decreases, it reduces the risk of using against one's planning, which doesn't mean that you need to be abstinent. I'll go back on that. So what could be goals for medications for opioid use disorder? There's one major goal that should always be of concern, of course, is overdose prevention. There's a goal which is reduce and prevent withdrawal that traditionally was a primary goal for doctors, but should today be considered a secondary goal, and the primary goal should be avoid relapse through management of craving, keeping in mind that not relapsing is not just not being abstinent, it's unwanted use. And of course, the only way to know if someone has unwantedly used is asking him. The urine toxicology cannot tell you that. I agree. And a final point is that the optimal dosing, actually, it's always too low. Higher is better, especially that the goal that is achieved at lower dose, you only have, so you will have advantage for the user, but only partial advantage. So you will have also some discomfort that it's helping me, but at the same time, it's not helping me. So the user can experiment some kind of handcuffed. But if the dosing is appropriate, then the user can experiment going back to doing things as he wants. And so he can feel free. So very opposite experiences. So to finish, we need a shared treatment perspective where there is no condition for treatment access other than a clarified diagnosis. Once we know the diagnosis is there, there should be no other conditions to access treatment. The other thing is a clarified objective for treatment. The objective is to reduce relapse rate and intensity, not to make it disappear. So reduce the frequency, which means that each time there is a relapse, you can calculate frequency and eventually document that treatment is very effective because the frequency of relapse is actually going down, which is treatment success. Not relapsing again, abstinence is possible, but abstinence by itself is not good enough and actually is not needed in craving-centered addiction treatment. We need an explicit target for the objective, which is identifying and monitoring craving, and targeting craving with medications in patient-user-friendly formulations, and that's going to be an issue, a discussion with the other presentations. Keep in mind the need for access to reward. So if the opioid becomes an object of addiction, but for that subject was also an object of reward, what are the alternative rewards does he have in his environment? Sometimes there are many, it's not an issue. Sometimes there are not that many. So it becomes a medical issue to be considered. And then finally, abstinence or use reductions are going to be not prerequisites of treatment, but consequences of treatment that are shared between the health professional and the user to determine, okay, are we going on the right direction? Have we achieved a good enough goal? Do you want more? Do I want more? And so on. Thank you.
Thank you, Marc.
Thank you, Mark. And I believe, as we progress with the presentation, we'll just, put, people more and more at the center, starting with the next presentation. The presenter is Magdalena Harris. We'll try to, guide us a little bit through social science, the social perspective. Dr. Magdalena Harris is an associate professor at the London School of Hygiene and Tropical Medicine, and she's very passionate about community engagement and building links between community and drug user organization and social research institution, academia.
Thank you, Mario. Good to see you all, and yeah, it's a pleasure to be here today to talk about person-centered choice. So I've been asked to give a social science perspective on person-centered choice and treatment options. And I guess thinking about, well, what do we mean by choice? What do we mean when we think about this? And often the first thing that comes to mind is providing a good choice of drug so that people have the choice between methadone, bupe depot, heroin-assisted therapy, etc. And this aligns with a natural science or a biomedical approach, as we've just heard, around which is mainly that drugs have stable properties, and it's about finding the right drug for the right individual with attention to drug-drug interactions, comorbidities, side effects, administration, dose, etc. But a social science perspective would complicate that, and would even complicate the notion of choice, and think, well, what do we mean by choice? Choice is constrained by context. Not everybody has the same ability to choose. And that thinking about choice and person-centered choice can actually be problematic because it could put all the impetus upon the individual. So if they get their choice wrong, then it's their fault, instead of thinking about the circumstances which may be constraining that choice. So, and we would also think, that the experience of a drug is going to differ according to the context in which it's provided, and it will differ according to social norms and meanings around that drug, issues around policy, power, access and environment. And so I'm going to give you some examples of what I mean. So if we look at the social science literature on choice and opiate substitution therapy, people who use drugs, we can see that choice is complicated. It's not as simple as somebody expressing, yes, I like methadone, or yes, I like bupe, or no, yes. Many people express a profound ambivalence about these treatment options. It's not straightforward, and we need to honour that. And you can see these examples here. So if we think about methadone as an example only, methadone can be seen to enable freedom. It can provide stability, it can reduce the threat of withdrawals, of having to deal with adulterated drug supply, need to generate money, fear of arrest, etc., etc. But it can also be seen to constrain freedom and be controlling. And I think many people are probably familiar with the term liquid handcuffs in terms of methadone, and often the controllers around restrictive treatment regimens, which can be stigmatising and constrain work and lifestyle opportunity. So these are quotes from previous work I've done with people who use drugs in London, and Keith Both says, the methadone has given him some freedom. He, previously he was going out begging every 10 minutes, and have been on the methadone's made a hell of a difference. He doesn't have to do that anymore. But he also says it's horrible, really, really nasty shit. He doesn't actually like it. So there's an ambivalence there. Again, James talks about methadone enabling normality. He said, my main priority is to live some sort of normality of life, which methadone allows me to live at home, etc. But it also precludes normality. The way the treatment is provided means, he says, my life's just like one big fucking appointment. There's no joined up thinking. So choice is not straightforward. So we can see that choice is complicated. Many people who use drugs express ambivalence about treatment options for opioid dependence, but we can better understand this ambivalence and facilitate choice by attending to context. So I'm going to give some examples in relation to context of prescribing, dispensing and consumption. And I want you to think about how might changing these conditions alter people's choice. So in terms of prescribing, you know, who holds the power in this prescribing relationship? Is it shared? And, you know, if you think about the context of choice, in Dylan's case, Dylan says, sit there, keep your head down and shut up, because they're writing the scripts. It's always been like that, always will. The person who writes the script, they hold the power. You're not going to do anything to piss them off. So, you know, there's a power imbalance there. And this needs to be taken into account when we're thinking about what choice is and what are the circumstances that are going to allow it. What guarantees are there in place for confidentiality and continuity of prescribing? What, for example, as Amy says, if you're a woman and you're scared to disclose that you're using drugs for fear of having your children taken away? So how is that going to enable person-centred choice? She talks about women suffering in silence, buying it on the street, not wanting to engage. So there need to be the prescribing context, the context needs to be right for there to be able to be a choice. And we think about dispensing. How friendly is service provision? Are conduct contracts in use? Are they in use for all customers? People who come in for their diabetes medication, do they have to sign a contract? Often not. But as you see here, Jeff from a previous work of mine said, some pharmacies you have to sign a conduct contract. If you're intoxicated, they won't give you your methadone. Fine, but I don't like the idea of getting works from there because I want to minimise any chance at all of using that as an excuse not to dispense. So Jeff has been precluded from accessing clean needles and syringes from his nearest pharmacy because he's on a conduct contract for his methadone. And again, I just want you to think about these contexts in which prescribing, dispensing are taking place, and what that means for somebody's choice. It's not actually necessary around the drug, is it? It could be any drug, but if those conditions are in place, then that's going to impact how somebody feels about the drug. And we can think about consumption. You know, what messages do the consumption context provide about trust, and how might this then impact upon engagement? And, you know, I've used these quotes before in presentations because I think they're very powerful. I wasn't asking about trust, but both of these people just brought up trust as an issue. So Jeff, he said he's been on weekly takeaways. He talks about the freedom that enables and says, I've been trusted for a long time. Hacky, conversely, says that he's still on supervised consumption. I don't know what they think I'm going to do. It's silly. It pisses me off. I'm too angry with the system at the moment. I don't really engage. Why don't they trust me? So again, this could be methadone. It could be bupe. It could be any other drug, really. You know, it could be your diabetes medication. If you have to go in there and get it every day, it's going to impact how you perceive that and the power relations that are operating around that particular drug. And how much you feel that you're able to trust other services, you know, the trust that's been given to you, and then how much trust you have. So it's a two-way street. So if we think about this ambivalence, you know, how can we work to mitigate it, and how do people work to mitigate the ambivalence themselves in their everyday life? Because it's quite a hard thing living with this ambivalence. And one thing that's been very important, I think, for people is the ability to self-regulate. And this is only afforded by flexible dosing protocols. Both Abby and Kyle talk about the importance of being able to take their methadone when they want it, how they want it, and that actually this is enabling them to cut down in their own way and giving them a sense of self-efficacy and self-control. You know, Abby says at the end, it gives me control of it. I'm in control. It's not controlling me. And I think that's incredibly important to think about in terms of choice. So if we can think about, you know, these contexts as creating this sort of dissonance for people of ambivalence, might long-acting formulations like bupe be the solution, right? You don't have to go every day. You can get an injection or an implant or whatever. Okay? Yet, surprise, surprise. Early social research into this, again, people are expressing ambivalence. It provides freedom, removes daily restrictions, etc., but it's also seen to be removing control or being controlling. People talk about that it's disempowering. One participant said, I want to be in control, not some substance under my skin. There's concerns that it feels too invasive. You know, another participant said, you want to know you could remove it. For example, if you had a bad reaction, which is a pretty important point, I think. So if we think about, you know, I think we need to consider that choice isn't just about providing lots of different choices of treatment options, and choice isn't necessarily straightforward. But to honour this ambivalence and work with it. And in the example of Bupe Depot, for example, you know, it offers freedom from restrictive treatment regimens, it can capacitate work, holidays, etc., and will be embraced by some. However, it also removes control over drug administration and effect, and will be perceived with suspicion by others. And I think this is particularly important to think about in the history of depot treatments. If we think about Depo-Provera, and the very problematic history of these drugs being offered to marginalised and tested on marginalised populations. And so it's very understandable that there's suspicion amongst communities of people who use drugs, and to recognise that and honour that. So I haven't come up with any answers, but I see my role as more as posing questions and complicating this question and this idea of person-centred choice. I guess I'm a bit sceptical, really. But I want us to think about, if we're thinking about choice and how to enable it, is ownership of the intervention and its implementation top-down or shared? How are treatment goals arrived at, and whose needs do they meet? For example, the goal of stability. Is this a client or a practitioner goal? Is it a policy goal? Is it something about getting the funding? You know, this quote from Joe Neal's work, he says, I don't like the sound of the depot, it means you're on a level for the whole month. I used to like getting up in the mornings and taking my methadone, knowing in half an hour I'm going to have that really warm glow inside. So what options are there for people who want to both self-regulate and feel the drug effects? You know, is this a viable treatment goal? And, you know, and I'd also like us to think, what might the treatment landscape look like in the context of safe supply of safe drugs, such as compassionate clubs are doing in Vancouver? What is treatment like methadone offering? Is it treatment against dependency and withdrawal, or is it treatment against the effects of prohibition? You know, of fear of arrest, of having to generate money, of stigma, etc., etc. If people could get free heroin that had been checked and was safe, you know, what would the demand be like for these other treatments? So I think, you know, we need to think a bit more broadly around what we mean by choice and the contexts in which drugs are provided, not just think about having a variety of different drugs, although of course it's incredibly important too. So that's it for me. Thank you.
Thank you, Magdalena. Now, for the community perspective, we're pleased to welcome Judy Chang, who is the Executive Director of INPUD since 2017.
I feel like the bad in class because I don't have a presentation.
That's good.
Magdalena, you're really tough act to follow. Hello, test. Okay. So I think, you know, we are here having really important discussions. I do think the ways in which people who use drugs are treated within opiate agonist treatment programs aren't really investigated or often given enough attention or a platform. Very often it's assumed that we should be merely grateful for having access at all, given, you know, we do have to acknowledge that the vast majority of people who inject drugs globally do not have access. But as Magdalena mentions, and I think she put it really beautifully, she talks about the ambivalence that people who use drugs feel about enrolling in OAT programs. And that's really because of the tensions that she mentions between care, freedom, and coercion on the other side that are really baked into treatment programs all around the world. So I've been on OAT, either methadone or buprenorphine, for most of my adult life. And the last time that I entered into treatment, I really struggled with the decision to actually enter again or subject myself to the treatment program, because I also knew I would lose rather than gain control of certain aspects of my life. So of course, without doubt, OAT enables stability. It has kept me protected from overdose most of the time, has been a lifeline during times when I couldn't fund my drug use. It meant I could avoid the pain and horrors of withdrawal, and also helped me to self-regulate, as Magdalena mentioned. So not necessarily to stop my drug use, but be able to manage it better. And it also means not having to expose, myself daily or repeatedly to the danger and violence that does occur when you're purchasing drugs in a criminalised market. But of course, it's not straightforward. On the flip side, treatment programs create a lot of unnecessary stress and anxiety because of the way it is structured and designed and delivered, with all the rules and procedures which at best are arbitrary and at worst can actually be punishing. And of course, the relentless stigma within the programs. And the problem is that many of the practices within these so-called harm reduction programs can't really be described as anything other than dehumanizing. So one, if we look at the indignity of mandatory supervised urine testing, where many clinics will have cameras installed in the toilets. One drug user activist has spoken to me about the humiliation of being in high-level policy meetings with the same doctor that observes her peeing into a cup weekly. It's very difficult to negotiate or have equal bargaining power within that relationship. Of course, there's the lack of take-home doses because of this fear of diversion, the mandatory fortnightly visits to not only doctors, but as I'm seeing more and more, mandatory visits to social workers and psychologists, which is more unnecessary intrusion. So it's really difficult to see this as being characterized as care, when if you miss an appointment, you're at risk or you fear being kicked off a program. And of course, many people are suspended or expelled for missing doses or using drugs. So I think we can all agree this isn't person-centered care or person-centered choice, and it doesn't follow the basic principles and practices of standard healthcare. So what it feels like is that many OAT programs end up being a biomedical tool which are delivered through these social control mechanisms. And there's this kind of carrot and stick approach to try and shape you into the person that they think you should be. I'll just grab some more. And we don't just see this in the rules of treatment, but we see it in what kind of intervention or medication is pushed or prioritised by the system. And this is at the expense of our preferences, and sometimes I see at the expense of lives. So Magdalena did discuss the tensions with Depot Bupe and the problematics and ambivalence that people feel about it. In 2019, INPUD published a position paper on Depot Bupe, really urging caution in its promotion. Though it's highlighted as an intervention that will liberate people who use drugs from daily attendance, it's really about greater control of people who use drugs. And we see this over and over again. It's not new. We see it from the insidious replacement of Subutex with Suboxone to stop people injecting drugs or feeling pleasure or topping up, to naltrexone tablets and implants that were heavily promoted in the 90s to again enforce biomedical abstinence and really put people who use drugs at risk of overdose as well. So recently there was a brilliant episode of Crackdown. I'm not sure if many people here know or have heard of it, but it's a podcast run by people who use drugs in Canada with a wonderful Mullins as the host, and there was an episode called Cop Baked In, and followed a young woman's journey, Ria, on her Suboxone journey. So how she summed up her experience was this: people get high for a reason. You can't just take it away from them. That's not going to work. If a drug is blocking you from getting your needs met, then that means I'm not getting my needs met. I just don't believe you can deprive somebody of their coping mechanism and whatever family and social connections they have and expect that they are going to get better. That's what causes most of the trouble. It's other people designing drugs for us, but really they're designing it for themselves and what they feel comfortable with. And that's never going to work. So I think the key question that Magdalena also brought up that we need to be asking is, who is this intervention for? So of course then there was COVID, which strangely did open the door to actually start making some of the changes towards more person-centered care. Almost seemingly overnight, take-home doses were introduced for the first time in Vietnam and Nepal, and mandatory urine tests suspended. Of course, this was a positive development, except for the fact that it took a pandemic to actually compel change in a system that we knew all along was broken. And except for the fact that many countries are now rolling back progress. So I think we really have to push harder for harm reduction to remember its roots, and that is non-judgmental care and meeting people where they are at. So we can't keep on accepting it being chipped away by the recovery agenda. And maybe it is this growing political emphasis and slogan on person-centered choice that can help bring harm reduction back. So I've got 2 minutes, but just to run through some points of what person-centered care would look like and what it means. So it does mean having as many tools in the toolbox as possible: methadone, buprenorphine, heroin-assisted treatment, and not having our choices limited solely by structural discrimination nor moralist ideas. It means being simply treated as human. You know, the number one reason that we hear of why people who use drugs avoid healthcare, including harm reduction services, is because of the shame and judgment. The main reason people give for valuing a service is because they treat it as a human being. But I just don't know how we can continue supporting a system or not wanting to change it when being treated as and respected as a human being is somehow considered a rarity. Person-centered choice means listening and believing people who use drugs when we tell you if and what treatment we prefer, how and by who we want it delivered. We don't need well-meaning people or interventions that don't listen to us when they haven't lived our lives or had our experiences. So just to finish, you know, I just wanted to bring up again what was said in the opening plenary, that ending and challenging criminalization is the first step. You know, I don't think any criminalized group, by its very definition, will ever be believed to be fully capable of making choices of our own free will, volition, and agency, including in treatment programs. So they really, you know, we need to be pushing these things together and in tandem. Thanks.
Yes, thank you. Yeah. No, thanks a lot, Judy. That was really perfect. And again, at the end, we'll have plenty of time. That's why we're trying to rush some of the presenters. I'm sorry for that. So the next speaker is not here in person. It's Barbara Broers. Barbara is a professor in addiction medicine and has been working in Geneva for 30 years. In opioid agonist, was instrumental in introducing safe consumption room in Geneva, heroin replacement. So there's a lot of history. So she couldn't come, but she sent a video, which we are going to show to you.
Thank you, the organizers, for inviting me to participate. I will continue this session on implementation issues. My name is Barbara Roers. I'm a professor in addiction medicine in Geneva. I've been working in the field of harm reduction and treatment for different forms of substance use disorders since 30 years. This is the short outline. You can see I will continue straight away because we have only 10 minutes. First thing, if you talk about treatment options for people with opioid dependence, you have to think of three different things for me. It is the treatment option. Will it be access to harm reduction services only because a person is not ready to stop opioids, but decides to continue? Or does the person want to stop the use and needs help for withdrawal and relapse prevention? Or does the person prefer opioid agonist therapy plus associated services? And in a certain country, these options have to be available. Then there's the option of the different medications, be it opioid agonists, the different ones as you see here, or opioid antagonists and different medications for comorbid disorders. And finally, very important is the setting. Is it a specialized center, private practice, health centers, and with or not a pharmacy option for the medication delivery? And is the treatment free, anonymous, reimbursed? Is there registration or not? Or does the person have to pay himself? Sometimes there's a link between the setting and the medication options. We'll get back to that. In short, I've been lucky to work in Switzerland, where people have access to harm reduction, rehab centers, and different opioid agonist treatments. This has been proposed in specialized centers, public and private, but also, very importantly, and at least for half of all the treatments in GP's practices. The medications that have been available is methadone since 1985, heroin since 1994, buprenorphine since 1995, and long-acting morphine since 2013. All the treatments are available in the centers and in the GP's practices. Only heroin prescription is in specialized centers. As you can see, we have no Suboxone in Switzerland since there is no demand. The medication delivery can be either in the center or in practice or in the pharmacy. In general, people can take home dosages, beginning for only a few days, and it goes slowly up to once a month, and it has increased during the COVID restrictions with very good results. All treatment is reimbursed by the basic medical insurance without a time limit. For each prescription, there is a need for a cantonal announcement. That means that the person has to give his identity. And there are some sort of central statistics that allow us to see how many treatments are ongoing. For the practitioners, there's a national website called Praticien Addiction or Addiction Practitioner, available in French, German, and Italian. And they have lots of practical and clinical suggestions and a helpline. But there are also regional associations of prescribers who provide supervision training. And finally, we have the guidelines from the Swiss Society for Addiction Medicine. So there's also some form of continuous education for practitioners. What do data say? Just to know that in Switzerland, we have a population of around 8 million people. And the estimated number of persons with opioid dependence is around 30,000 with a question mark. In 2020, 16,000 people were in treatment, oral agonist treatment. A quarter were female. Average age is 47.3 years. It has been going up since many years. The heroin prescription concerns around 1,700 persons, and this is stable since at least 10 years. As said, there are specialized centers, and in general, there are for people who have specific needs. They have access at the same spot to a GP, a psychiatrist, a social worker, nurses, etc. The medication delivery is around 50% in the pharmacy, 27% in private practice, only 20% in centers, and 1% in prison. And the medication preference is really methadone still, although it is decreasing. What we can say is that overall there's a high treatment retention rate and a low overdose rate in Switzerland since many, many years. Here you can see the number of persons who have been in treatment since 1985 up to 2020. So a huge increase between 85 up to around 2000. And since then has it been stable for at least 10 years and starting to slow down now. This is interesting, I think, to see what kinds of substances are prescribed. As you know, people have the choice. So what do people choose? In the beginning, it was only methadone, in 2000 or mostly. And then slowly, this is without heroin prescription programs, just to be clear. Then there was buprenorphine available on the bottom, and it has been slowly going up, but never went beyond 9 to 10%. Then the long-acting morphine, it's called morphine retard, has arrived in 2013. You see a slow increase in the beginning, and it continues, and it is now around 27% of the treatments. And with that, the methadone treatment has gone down. Oxycodone and levomethadone are very, very low. What can we see with these data? Methadone and private practice are the favorite choices of the people with opioid dependence in Switzerland. There's no interest for long-acting buprenorphine, and there has been a rising interest for the long-acting morphine. For my clinical experience, I can tell you this is in part due because the doctor will propose it. It's an aging population with a lot of polypharmacy, and long-acting morphine gives less interactions than methadone. But often for people, it is like, I would like to have a change. I've been a long time on methadone. I would like to change something, and maybe the long-acting morphine can help me in that. But also there might be other reasons, such as the increasing value of long-acting morphine in the black market. And we see more and more diversion with also people injecting the pills with many complications. I have to say that I think there's a lack of evidence for the cost effectiveness of this treatment. And another problem we have is that since a few months we have supply problems, major supply problems, and because of problems probably in the United States with the firms making opioid treatment. We still think that diacetylmorphine is the best option for persons with opioid dependence and who cannot abandon injection. And for the clinician and for the patient, I think it's very of great value to have these different treatment options because you really create a partnership. You can discuss about the advantages and disadvantages of different treatments. So in conclusion, in a setting where different medications are available in private practice and in specialist centers, methadone seems to be the most preferred option and is probably also the most cost-effective option. And we need more data on long-acting morphine. Our experience also shows that GPs can integrate opiate agonist treatment as like another long-lasting treatment in their practice with a minimum of training and coaching. And this can be for all substances, be it methadone, buprenorphine, or morphine. So there's no reason to link a certain medication option to a setting, such as buprenorphine only in private practice or Suboxone only in private practice and not methadone. And so, well, my recommendation would be really to have all these options available in different settings, because this is beneficial for the person with the suffering from the dependence and for the clinician-patient relationship. Thank you for your attention. If there are any questions, I'd be most happy to answer them by email. This is my email address. Thank you so much.
Thank you, Barbara, from where you are. So now for the policy perspective.
Thank you, the organizers, for inviting me to participate. I will continue this session.
So we're pleased to welcome Matt Southwell, who is the project executive for the
implementation
EuroNPUD.
issues.
It's okay? Perfect.
My name is Barbara Bruce. I'm a
Okay, so thank you very much for inviting me to contribute to this session on supporting person-centred choice. Yeah, can we go to the next slide? So, oh yeah, I'll go back one first. I'll wait for a minute. Oh, thank you. Okay. So, in terms of talking from a policy perspective, I have been a professional head of drug treatment services in East London and City during the 1980s and 90s, and I was professional head of service over the psychiatry team because it was the local mental health trust wanted a new direction in how we were running drug treatment, and they wanted a multi-professional model with multi-perspectives. Psychiatry was an important part of the team perspective, but it was one of a multiple range of perspectives. I was also involved in setting up shared care, and we were involved in establishing the primary delivery of OAT through general practitioners, but then establishing specialist drug clinics that were able to manage those people with acute or chronic conditions and to take people over rapidly so that general practice had the confidence to manage the vast majority of people. And we saw general practice as an optimum place for care because they were very good at managing the broader healthcare needs of people who use drugs. So, looking at the UK has been a disastrous place to be a drug user in the last 15 to 20 years. We've seen the destruction of the British model. However, it provides a very interesting space to look at the consequences of changing your policy perspective and what impact that has then on your the context of delivering drug treatment, and particularly the place of the client in that space. So thank you, UK, for giving us such an interesting case study that has killed so many of my peers in the process. So the first period is the period in the 1980s to 90s where we had a policy driven by this unique context. We had this HIV outbreak in Edinburgh. It turned out to be very exceptional. We had 50% of the injecting drug using population having HIV. There was a huge fear that this would be replicated across the country. Before they realised it was an exceptional case, we had introduced harm reduction and had this model founded on a desire to prevent the transmission of HIV among people who use drugs, and probably more fearfully that we might infect the more general population through our sexual partners. Now, because of that, the government asked the Advisory Council on the Misuse of Drugs, this is the professional body, bringing together all the professional disciplines, they asked the ACMD to drive policy. So they said, so the ACMD wrote 3 reports called the HIV and Drug Misuse Reports. They were exceptionally good reports. The first endorsed needle and syringe programs and opiate agonist therapy. The second endorsed outreach. And the third endorsed community models. The professional sector was quick to adopt the first 2 and failed profoundly to adopt the third. Which again I think speaks to the power dynamics. Now, it speaks to the fact that the treatment sector, the harm reduction and treatment sector embraced harm reduction when it was still professionally driven, but when it became a more formal partnership with peers, people were much more reticent of that. And I think that is partly because of treatment relationships. It's people trying to break out of a way of working with us. So, during this period, we had this time when the focus was on reducing injecting, access to HIV testing, and obviously then on into treatment, and recognising the important role of opiate agonist therapy or opiate agonist treatment as a methodology of helping people stay engaged with their antiretroviral treatment. So given that, the context then was, let's give people high dose, let's give people long duration. Methadone was probably favoured over buprenorphine because it had this stronger treatment retention effect. And actually, given the HIV outbreak in Glasgow, there's now an increasingly discussion about saying actually those treatment options are not enough to engage the most vulnerable population who are most at risk from HIV, and that's why there's a big push for heroin-assisted treatment now as part of this enhanced HIV response. Now, within that model, we benefited from this galvanizing effect that HIV had on medicine generally, which was particularly the men who have sex with men community, but benefiting other populations as well, this push for a new type of client-centered care. And it did impact on the drug treatment sector to some degree, I think is fair to say. So this was the optimum period. For me, I thought this was the triumph of rationalism over outdated practice. The thought we would ever go back from this seemed inconceivable, and then we went backwards. So then Tony Blair comes in, and Tony Blair thinks we've done HIV, so therefore we've got to come up with a new justification for opiate agonist therapy. So this is his mantra: tough on crime, tough on the causes of crime. So again, that need to be tough. No, the undeserving poor, we keep getting on their case. That shifted the dynamic. We have a huge investment in opiate agonist therapy, nearly $500 million being spent on opiate agonist therapy. But it was about getting offenders into treatment. It was about getting people away from drug-related crime. And that shifted the nature of opiate agonist therapy. It became about urine testing, monitoring, checking on you. You could be withdrawn to prison if you didn't comply with treatment. So a real shift, and it became much more, we've described it as a hostile environment. This environment of really not trusting drug users. So this was the key. The place of the client in this new model is not to be trusted, is to be monitored and tested and sanctioned if they don't comply, and even to be withdrawn to prison if they fail to comply with the programs. So to have that, not just you could lose your script, but you can be withdrawn to prison, seems a pretty it's a pretty substantial shift in the model. We then move into another model, which is the recovery model, where the government is now persuaded by a minority bunch of kooks, to be honest, a small group of recovery ideologues from Scotland, who are old-style Puritans, frankly, who got to the government in the period where the election had been called. So civil service couldn't give them advice. By the time the government comes back from the election period, they've signed up to this recovery model. And in reality, it's largely an excuse to cut services by 25%. So this is austerity. They introduce localism because then somebody else has to make the cuts, claiming it's about public health when it's nothing to do with public health. It's making local authorities make tough decisions that government should really be making. And there's a use of recovery self-help groups as cheap treatment, recovery volunteers or recovery champions as an alternative to professionally trained workers. And Dame Carol Black has just done a review of drug treatment services in the UK, describing the terrible vandalism of the British model. I mean, it's a disgusting change. We have workers now who are turning to the drug user movement to teach them how to do harm reduction, because practice has been that skill set has been completely lost in many of our service providers. Within this model, then suddenly Suboxone becomes more interesting, long-acting buprenorphine become much more interesting, and notably we have this constant refusal to consider giving us full agonists. So here's another partial agonist, here's another partial agonist, which I have no objection to. I think they play a role in the treatment system, but why give us part of the system, not the full system? And a Swiss psychiatrist talked about this fear of the flash effect. Now, the idea that opiate agonist treatment or drug treatment might give us pleasure is somehow an anathema within this process. A wonderful Dutch psychiatrist once said, why is it that we worry so much about healing people's pain? What is it that stops us wanting to help people who we know are survivors of childhood sexual abuse, people who've lived through trauma, people who've grown up in care, people who could benefit from lifelong psychotherapy, but we don't offer it. So then why are we not willing to give them something that might heal that pain? What is it that stops us wanting to do that? And I think one of the mental health practitioners, mental health activists I read said, Who was it who decided that I get to live a life of permanent recovery and someone else gets to live a full life? So my life is all about a deficit and somebody else's life is full. And this was a mental health activist, mental health recovery. Sorry, this was a mental health patient questioning recovery, not a drug user activist. So I then wanted to think about, well, if we could do it differently, let's imagine a model that wasn't founded on these principles, but was founded on the principle of health and happiness, that was really trying to say, we want to support people with drug dependence to live full and happy lives, fulfilled lives that support people to achieve a full, the highest attainable standard of health. In the UK context, that would require us to withdraw the Misuse of Drugs Act, to recognise that we can't continue criminalising a population and then expect doctors and drug users to create a clean space, I mean in communication terms, not in drugs terms, a space where we can talk and create therapeutic relationships. When one of us is criminalised, that equality is asking doctors to achieve something that is very difficult. I think if we had a legal regulated system where money was being earned through taxation, we could use hypothecated taxes to actually make sure that funding was allocated to those, or taxation was raised in a way that allowed higher risk drugs to be backed up with effective drug treatment. And also to recognise that if we did drug policy well, there are huge cost benefits that could be achieved. This is not about expensive drug treatment. This is about saving society huge amounts of money. In my hometown of Bath, where we have 1,000 drug users, we lost 3 people from septicemia last year. They spent 2 or 3 months in about 5 or 6 of them spent 2 or 3 months in hospital. A decent OAT system would cost far less money to run than that type of system. So in this type of model, we would be looking at personal growth and development, healing and support, family cohesion and good parenting, employment and education, and stronger and safer communities as the goal of treatment. A treatment system that persecutes you, intrudes into your life, and threatens you with withdrawal of treatment all the time, that couldn't possibly fit within a model that was trying to be framed on health and happiness. I describe myself as an ambivalent user of opiate agonist therapy. I think it's wonderful. I'm here able to speak to you because last week my doctor gave me methadone and gave me take-home methadone to come to this clinic. I couldn't be standing here speaking to you if he hadn't shown me that respect, and my pharmacist is fantastic too. I'm not opposed to them. I'm opposed to the policy environment that surrounds us, that stops us creating therapeutic relationships, and that's what we should be able to do in a model founded on health and happiness, not on recovery and not on crime reduction. Thank you.
Thanks a lot, Matt. I think you just, help us get ahead of what we wanted to discuss. Can someone turn it off? So all the speakers, otherwise it's really hard with that lamp. If you can come here, or we can have the panel from, I think it's better if you come here, because the idea of the panel is, well, first, to encourage everybody to ask questions, but also to try to understand how would, like, a people-centered framework should look like. And I think you just, it's really, it depends what is the framework behind, all this too. Is this fear of HIV, it is unrealistic recovery agenda and elimination of crime, or just, what I really like, the health and happiness, agenda seems to be something that will certainly subscribe. So I will probably start with questions from the audience, if you have any question first. And then, if not, we can invite the speakers to keep, reasoning around this topic. But first, since you've been listening very, very diligently for an hour, is there any question to any of the speakers?
Stunned silence.
No questions, so everything is or comments. No. So it seems to be easy to better integrate patient preferences in the choice of the treatment. No,
Okay,
No,
I'm
there
going to
is a
say
comment.
something because nobody
Yeah,
has said
sure.
anything, and that those were brilliant performances. Thank you all very much. Excellent.
Thanks.
The dissonance between the world that we're inhabiting and the world we're imagining and thinking about how we can bring about here is massive at the moment. And I am slightly stunned, I must admit, when I sit and think about the actual context that we're operating in now, which is genuinely appalling. I've already made this point as a speaker this morning, that I don't think harm reduction can go very much further apart from providing sticking plasters for people without actually ending the war, the larger project of drug prohibition, which I think has been one of the steps that historically our societies, adapting to the modern world, of which drugs have always been a part, I think it's one of the worst steps we've taken as societies, and trying to undo it is going to be probably a long game, as we already know. I mean, I just wanted to say something really, and to thank you all, because those are inspiring words. Anyone got any further words to say on how we can actualize them? Yeah.
Take off the mask. I'm Martin from Denmark. I'm a nurse. I work with drug users for 6 years now. And the methadone treatment is working, and then it's not working. And it's, like you said, it's always this fight for the user to get his methadone, and you have to go to the center every 3 days and get your methadone, and if you don't act by their rules, you are pretty fucked. And I don't know how to put it, but it's always the same struggle, and if the users could just get what the fuck they want, it would be way easier not to have this constant battle and the stress about getting your drugs and getting your treatment, and never minding the underlying reason to why you take drugs. So there's a million reasons, a billion reasons, like how many people are there on earth, why do you take drugs? And more willingness for the government to understand why people are using drugs. It's always this stigmatization with drug users, and there's always a reason why you do drugs. But then again, the methadone pills, then people sell them because they need money, and there's this endless battle with people injecting methadone pills, which is very harmful. And why couldn't they just shift over to IV methadone, but maybe go back to the pills? And we need a system that's more like plastic in this handling of the drug use. More flexible system where you can choose your own way to do drugs, because in the end it's a choice to do drugs. You could maybe end up one day like quitting it, who knows, and who is to tell you you can't use drugs and you shouldn't use drugs? That's a big problem, and I don't know how to address it, really.
Thank you. Thanks. I just would like to make a comment and to make a parallel between this session and the session from this morning, led by EuroNPUD and the Dutch Association, because there was a very interesting discussion on how to take into account the freedom of patients on OST. And my question is how we could measure the gap between the system proposition and the patient expectation. And there is not that many data on this topic. And as a researcher, I would be very interested in proposing, collaborating with a association to set up a survey and to highlight the need for patients. So that's a proposition.
I mean, just to maybe reflect, where I first started being involved in prescribing opiate agonist therapy was in the team called the Healthy Options team, which was a drugs team, which was a National Health Service team, but half the staff were also drug users. And so it meant you had people on methadone, and we used to call it negotiation, not assessment. So we'd be sitting there and saying, no, tell us what you're using, what's your goals of treatment, who are you buying from, let's work out what drug best fits what you're trying to achieve. To start with, in the first 6 months, we would work out that people would say, I'm using this much, and we would say, okay, so you need this much drugs. They would come back straight away afterwards and say, please don't give me that much drugs. I thought I had to lie to you to get what I wanted. And it took 6 months to get people used to the fact that we could have an honest conversation and they would get what they actually needed. And 10 years later, I had a probation officer who worked in both the Healthy Options team and also in the medical drug outpatient unit down the road. And she said to me, look, I can see something happening among the two client groups. Can I do a case note review? So I said, yeah, that's fine. And what she showed was the Healthy Options team had twice the drug-free outcomes of the outpatient medical team. Now, HOT was a community-based team. We used to say, we don't give a fuck about your drug use, we give a fuck about you. We use motivational interviewing as a way of working with people. Whereas the other clinic that spent all its time telling people to stop taking drugs just built resistance, as we know that's what happens from motivational practice. So I think it was, we never were trying to get drug-free outcomes, but I think that's the contrary nature. The more you push for drug-free outcomes, the less you get them because people resist you. The more you focus on people's motivation, some will achieve abstinence, and others will achieve many other goals that are not abstinence. But I think it's the irony that I see the UK fighting so hard for drug-free outcomes, and more people hate drug treatment and don't want to come into drug treatment. Whereas, no, actually, when you say to people, what would you like, how can we work with you, it creates a whole discourse within which some people will choose abstinence, which is perfectly fine.
I mean, just, yeah, kind of thinking of way forwards, I really think that there needs to be investment in the power of unions and collectivization, the relationship between the client as a person who uses drugs and the prescriber and the doctor is always going to be unequal, and you feel like you're never ever going to be listened. And I think change, really only happens when you're kind of forcing people and putting pressure. And so I think there's, real power in unions, and we really need to be funding as well and supporting the political fight.
Yeah. Give the micro.
I just had a question, or to get your opinion on the ways that certain types of OAT are like incentivized. Like in Ireland, methadone is very focused on as a prescribers are given an incentive to prescribe methadone over other options, and how can we move towards getting more options for people rather than just methadone? Like, a lot of people that I work with and talk to don't even know what Suboxone is because they haven't been talked to about it. And those are the only two. There's been one trial recently about Buvidal, about the long-acting depot, but that's it, So I'm like, how can we move towards getting more, or any opinions on that?
Well, I know France had buprenorphine from 20 years ago.
Yeah, but in France, buprenorphine has been distributed since 1995 because of HIV epidemics and because it was necessary to have a rapid access to OAT. now methadone is still the main OAT in France. So it's the same curve that Barbara showed, that methadone is a bit decreasing and morphine is increasing, but not in a medical context because it's not recognized as a OAT, morphine. So users can have access through some negotiation with the physician, but probably if it was more accessible as a OST, morphine, it will be more prescribed. And so it's interesting to ask users what they want and what they need. And we don't do that enough.
Yeah, I mean, I think generally there's a lot of fear and resonance about Suboxone as opposed to Subutex. And I know when it was being introduced in certain countries, you know, the peers in the community were really concerned because they thought, okay, introducing Suboxone, which has a naloxone element, that blocking effect will mean it will supplant, you know, other interventions because prescribers, you know, feel more comfortable with Suboxone. So just, yeah.
Yeah, it's one of the things I have sleepless nights about a bit is the fact we worked very closely with Reckitt Benckiser around the introduction of Suboxone. And they had a very good patient involvement program, and you know, Chris Trapelio and the team at Reckitt's were genuinely interested in working with us as a drug-using community, and that was compelling. What we tried to do was our argument with Reckitt's was, rather than fighting for the small population of people already in treatment, why don't you develop a product that actually helps engage the population not in treatment? And we hoped that Suboxone would allow for a more light touch treatment. It would give people the confidence. And in Australia, AVIL, the Australian Drug User Movement, fought for Suboxone, supported Suboxone to be introduced. But actually, when it came down to it, when the Australian government offered them exactly the same licensing regulations as buprenorphine, the drug company took it because they wanted to be able to sell their product. From the drug user point of view, that felt like a complete betrayal. Every reason why we'd supported the introduction of that drug, and now we have generic Suboxone in India, and the drug users are sitting there going, where did this come from? And it just feels, I don't know, for me, Suboxone, and it's not even a regulated drug, it's hijacked the regulation for buprenorphine. There is actually no WHO regulation for Suboxone, and personally I think we should be challenging it as a human rights violating product, personally. And I think long-acting, for me, I've always been using diverted morphine. I've found it very, very helpful to manage it. I would not be on opiates now if I'd had access to short-acting morphine. Methadone for me is something I'm going to have to stay on for a period of time and then come off at Christmas. I would have been off 2 weeks ago had I had access to morphine. So actually not offering us the right products is actually inhibiting our choices. No, I'm now on a drug that's going to be much harder to come off, and it will be a pain to come off over Christmas, and it will make my Christmas much less happy. My source of diverted morphine has recently died, so therefore I'm back having to use the OAT system, and no, for me that's a struggle. I would much rather have safe supply and be able to manage. There is a population of people who really need intensive OAT, and I've provided services to that group, and we should absolutely not be taking away the complex, comprehensive services from that group. It's just that we offer a one-size-fits-all treatment model too often, which I think is misusing the skills of drug treatment for populations who don't need it, and then not giving the populations who really would benefit from intensive treatment, they don't get the support they need. And it's just frustrating, because I've worked in good drug treatment, and it's a really life-changing system when it's done well.
And it mostly depends on the people working on the treatment and whether they appreciate the fact that people start using, like using stimulants maybe during the weekend. They want to reduce because they want to enjoy life, and maybe really that the point is that also also OAT is still a patch toward the world we would like is not a world where people have to go into replacement therapy. It would be more a world where people can have access to safe supply of their drug of choice, and maybe like support when they need it for a short period of time without being labeled as a patient or sick or what. So it's like, of course it's much better to be considered, patient than criminal, but it's still not what we want. So maybe in the last, we have about 10 minutes, maybe, you know, we can finish the session with maybe giving like a couple of minutes each, just to have a, you know, reflection about, you know, is it even possible to have, you know, people center in a system which is by design, there is a power imbalance, with the doctor more power, at least the power of labeling the other person or putting people in very, like, you know, difficult situation where dignity is also put into question, and what we can do. And it may be time to, you know, harm reduction, always trying to keep away from drug policy and keep it, but maybe it's time also to say that the only way is just to go for a regulated market, and decriminalization is probably not even enough. Maybe we can just finish this. And
so
unless,
let me.
Unless there's other questions, of course, or comments.
Southeast Europe, very quick. Where countries used to offer methadone or buprenorphine or Suboxone, and very often the choice is made because of the pharmacomafia. Actually, the relation between doctor and the producer. Of course.
Yeah, so I think the solution is a collaboration. I mean, my experience working at the Healthy Options team was it was successful because we had traditional NHS employees with all their skills and drug users with all their experience and understanding of our lives. Bringing those two things together made us such a powerful team. Now, Chris and I are working with Dr. Adam Winstock to develop a new tool which is called SODA, which will help people assess whether they are accurately dosed or not, so that we can have an objective tool that works out, are you underdosed or not? So then you can have a discussion with your doctor. And so if we can start to create tools like this that uses technology to allow us to have helpful conversations, I think you can imagine how that in the future could also look at maybe drug types or drug options. I think if we can start to take the pollution of drug control out of drug treatment, we allow therapeutic relationships to be more meaningfully developed.
Yeah, well, I couldn't agree more. It's a hard thing to know what to say. There's so many things you could say, right? I mean, yeah, I talked about context, but obviously it's important for there to be a range of drugs available, and I think also very important for there to be injectable options available in terms of the additional harms that are caused by people then injecting non-injectable options, you know, such as was mentioned with methadone pills, and you know, the things that are not meant to be injected. Well, if people want to inject, they're going to inject, right? I used to divert methadone in my mouth and go and cook it down and inject it. Not very healthy. But and you know what is provided, heroin-assisted treatment, is these highly restricted, regimented, you know, regimes. I mean, they're hardly anything available. We've got a tiny little pilot in Middlesbrough in the UK, and something else in Glasgow.
Trials have found it hard to even recruit people for the trials.
Exactly. So you know, it's again about. Yeah, it's about being more ambitious and thinking, you know, how do we really provide people with choice, and if people want to inject, providing them with injectable options that they don't have to go to a clinic twice a day to get, you know. So, yeah, because not doing so creates harm. It's not going to stop injecting. It's just going to create harm.
Yeah, I think it's a big question. But yeah, as I mentioned before, you know, I think the key piece is about how do we shift power, and I believe that comes from community mobilization and giving a voice, but it also means funding. And it kind of horrifies me when I think about how much money, millions of dollars, goes towards research institutions like NIDA, and they're trying to work out, you know, what is wrong with people who inject drugs or use drugs, and the brain disease model. When, as people in the audience have said, you know, drug use has always been a part of life. So, like, being able to equalize that funding, or, you know, find other sources of funding to go directly towards community-led organizations. And I think just secondly, like, you know, thinking about structures we can embed or put in place with programs. So things such as community advisory boards, right? So there's oversight over programs and also health practitioners, something that can be, you know, more long-ranging as well.
Well, for sure this is not easy to sum up, but I would say from my perspective, what I see, what strikes me, being in this field for some time now, is the discrepancy between the data, the fact, the different sciences, whether social science, medical science, psychological science, neurobiology, and the beliefs. And it seems that with time, this discrepancy stays. Matt gave the example of the UK. At some point, there was some kind of adequacy between what the data said and the organization, and then suddenly it changed. So, that's the challenge, and for everyone, and I think we need to. And the problem is that each of our communities, user community, health professional communities, so families of health professionals and families of users and society at large, everyone is kind of reinforcing his own beliefs and not looking at the data enough. And I think we need to take time to look at the data together and try to understand, because data by itself needs interpretation. And the more you are to look at the data and trying to understand what it means will help us go forward. And last point, it's possible that we need to tease apart different problems that kind of are merged together on this issue. One is the issue of the question, the legitimate question of civil rights of individuals to access to drugs, which is one issue. Another issue is addiction as a medical disorder and its prevention and access to treatment, which is a totally different issue. Another issue is how to manage chronic disorders. How do communities that need chronic help can access to that help, and how they can be held to accept, to support, to the impairment of needing some kind of long-term, and which is things that are seen with people with diabetes or asthma, or there's things to learn that they say things that sometimes I hear among us. So I think the challenge for the future is, you know, if you look 50 or 60 years ago, I think there's been, overall, my feeling, there's been progress. It's less worse. But we still need to go forward and to look at the data. Might help.
Just to give choice to the patient, we need to make sure that he knows exactly what is accessible. So that's one point. Giving him the choice is explaining what all the set of treatment are available, and also to give him the different settings, giving the opportunity to have access in different contexts. So, for example, in France, the French example shows that if buprenorphine has been so popular, it's because it was easy to access, and methadone is complicated still today. You need to be initiated in a specialized center, so it's not so easy to have access to methadone. So I think it's important to change and to have access to primary care to enlarge all these options for the patient. Yeah, you can go.
No, we need to close. Yeah. So I just wanted to thank you, all the speakers, and you for your question. I think we got into some interesting points, but of course deserve more discussion. But thanks again. We'll see you around. You can see the speaker if you have you want to continue the discussion. You can just enjoy the rest of the conference.